you very well.
Yeah, it's this play icon.
We are live.
So, Dr. Rao is not here.
Yes,
We are live.
Dr. Rao is not here.
Okay.
Yes, we are live. Dr. Aditya, over to you.
So, welcome everybody on behalf of AIS and the IOC. We are here to talk about ocular allergies revisited from pathogenesis to treatment. And we have stalwarts from all over the world who are going to address these topics. And we have our moderator for the session, Dr. Shweta Agarwal ma'am, who's from Shankar Netralaya from Chennai, and also my teacher. And we also have Dr. Srinivas K. Rao, who will not be joining us today, but his comments and all are with ma'am. We have Dr. Serge Doen from Paris, France, who's a global authority on ocular surface disease and allergic eye conditions. We have panelists today, Dr. Andrea Leonardi from the University of Padua in Italy, and she's a globally recognized authority on allergic eye diseases. We also have Dr. Chorespa, who's affiliated with the Clínica de Lluís in Buenos Aires in Argentina, and she's a prominent expert in corneal and ocular surface diseases. Dr. Nikhil Gokhale is also with us in the panel. He's a senior consultant at the Gokhale Eye Hospital in Bombay. And Dr. Pia Allegri from Genoa, Italy, who specializes in managing severe ocular allergies and refractive EAACI. And we also have Dr. Vanati ma'am, who's a professor from All India Institute of Medical Sciences in New Delhi, and she's also the editor of the very popular Indian Journal of Ophthalmology. So over to Shweta ma'am.
Yeah, hi everybody. Welcome to the ocular allergy session. And we are very pleased to co-host this session with the European Academy of Allergy and Clinical Immunology, that is the EAACI. It's a global organization with over 15,000 members spread over 124 countries. And its mission is to advance science, education in allergy and improve patient outcomes worldwide. Well, today our faculty is a multidisciplinary team of experts dealing with ocular allergy, starting with pediatricians to allergists to ENT surgeons and ophthalmologists, the cornea specialist. Well, a few of them have already been introduced by Aditya, but let me just reintroduce them. We have Dr. Serge, who will be chairing the session, and he leads the ocular surface unit at the Rothschild Hospital in Paris. We have Dr. Virginia with us, a professor of ocular immunology at University College London's Institute of Ophthalmology, who focuses primarily on immunological mechanisms in ocular diseases. Andrea, for some reasons, personal reasons, will not be joining us today. We have Dr. Vibha, who's a consultant in pediatric allergy at the Royal Manchester, and she specializes in pediatric ocular allergies. We have Dr. Pia with us, who's a senior faculty from Genoa, Italy, and again an expert in immunology and uveitis. Dr. Gonzalo Chorespa is a professor in allergy and immunology from Argentina and primarily focuses on allergic disease mechanisms. Dr. Neeraj, an internationally renowned allergist, our very own is from our very own Sir Gangaram Hospital in Delhi, and inspired by EAACI. In fact, he has founded a similar society in India called the Integrated Society of Allergy, Asthma and Sleep, and we all are really, really very happy with this, Neeraj. Thank you so much. We have Dr. Vanati with us, who is the editor of the IJO and a very, very dear friend, and she's a professor of ophthalmology at AIIMS, a person you can always bank on for everything. Dr. Nikhil again won't be joining us for some personal reasons. In addition to this dynamic faculty, we also have 4 dynamic young cornea specialists with keen interest in ocular allergies, and we'll be presenting some challenging cases. Dr. Anahita from LV Prasad Eye Institute, Vizag, Dr. Mukundan from Shankar Netralaya, Chennai, Dr. Nidhi from Shroff Hospital, Delhi, and Dr. Sugaranjani from Girdhara Institute, Cochin. So I would first request Dr. Serge, who's chairing the session, to give us the opening remarks, and then we can start with the talks.
Yeah, thank you very much, Dr. Shweta. I'm very proud to be invited and to represent the European Academy of Allergology here in India. It's the first time we have this link, and we have constituted a program with some members of our group, Dr. Allegre, Dr. Calder, and also Gonzalo Chonzepa, who is chairing. So we are very proud, and it's a very nice way of mixing our cultures and mixing the way we understand allergy. And we know that allergy is a very frequent disease. So but I won't take more time. I think we are going to listen to our first speaker, which is Virginia Calder, and we will learn more about the etiopathogenesis of allergy now. Thank you so much.
Thank you, Serge. This is a great honor to be invited to this lovely conclave. And I'd like to also thank Dr. Shweta for her invitation. I've been part of the European Allergy Working Group for many, many years, and it has been great fun, great pleasure to be involved. So I will promise to keep to time. My role as the scientist in the group is to discuss the current understanding of the etiopathogenesis of the various forms of ocular allergy. So I want to discuss the contributions of the different allergic cells, mast cells and T cells, but also epithelial cells during the different forms of ocular allergy and what we understand at the moment. There's a lot we don't understand. But the key thing here with immunology is achieving that balance of cytokines between the pro and the anti-inflammatory cytokines. And that's our goal, is to return the eye to a resting baseline phase. And then obviously a little bit about the future strategy. Where are we aiming to improve our knowledge and understanding this problem? So first of all, I'm sure everyone in this audience understands that there are different types of ocular allergy. It's a spectrum, and we have the milder cases, the seasonal allergic conjunctivitis. They're mild, the cornea is never affected, and out of season, the eye pretty much is back to normal. Perennial is also mild, but this time the allergen persists. And I understand that in many parts of the world, warmer countries where your flora and fauna persist for some time, the symptoms of perennial can last all year round, but can also involve other cells in the tissues. So whereas the seasonal allergic conjunctivitis involves mast cells, because of the persistence, other cells do get involved, probably secondarily to the mast cells. So we have some T cells, some neutrophils in the tissues. And then moving on to the more clinically severe forms of vernal keratoconjunctivitis, where the cornea can be affected. There is a seasonal worsening, but the condition is all year round. And then patients with AKC at the far right here, this is a sight-threatening problem. These patients all have a severe atopic disease, and I'm sure we'll hear all about these in later talks. So I'm not going to dwell on the clinical aspects. It's just to remind us all that immunologically, these are very different situations. So obviously, as I mentioned, the mast cells are the key driving cells in seasonal allergic conjunctivitis. We've known for many years that antihistamines and anti-allergic drugs will help to switch it off. So we know that the mast cells are primarily involved. Obviously, because of the perennial nature of allergens such as cat, house dust mite, then other cells do get involved here. T cells and neutrophils will infiltrate the tissue. So just a bit of the immunology here. For those of you who haven't looked at a picture of a mast cell recently, they store their cytokines. They're primed in an atopic individual. So they're ready to be secreted upon degranulation. And they're very important for interacting with other immune cells in the tissues. And these sorts of immune cells include eosinophils, which secrete a lot of very toxic products, as well as pro-inflammatory cytokines. So we do need to be conscious of the interactions of these different cells further down the cascade. And then my favorite cell, the T cell, which you will probably appreciate exists in a number of different subsets. Th2 cells are the predominant allergy-prone cells. These secrete IL-4, IL-13, etc., many Th2 cytokines. And that allows them to interact to help B cells make more antibody, to attract cells into the site. On the other hand, and you will be hearing about the Th1, the Th17 cells, these are more commonly associated with autoimmune diseases because of their secretion of interferon gamma, IL-17, but in fact are also, as I hope you'll appreciate, involved in some of the more severe forms of ocular allergy. So mast cells are central in these allergic conditions because we are talking about a mucosal site. The ocular surface is part of the mucosal associated lymphoid tissue. Lots and lots of mast cells present. And as you can see in the top left here, this is a recent summary of the various different cytokine receptors, chemokine receptors. Mast cells are incredibly responsive to their tissue environment. So they're very easily activated in tissues to respond, and that's why they're distributed throughout the body, but particularly at mucosal sites. They synthesize and store these cytokines in discrete packages so that they can be ready to be secreted within seconds of exposure to an allergen. They also synthesize more long-term cytokines. So, for example, cytokines combinations will affect a number of different cell types throughout the body. And as you can see on the right here, the mast cell is in the middle here, and IL-33 seems to be a very important cytokine that determines whether or not the mast cells are also involved in activating fibroblasts, endothelial cells, but all of the immune cells listed beneath are involved and affected by mast cell degranulation. So they really are the cells at the center stage of the immune response, whether it's an innate immune response involving neutrophils and bacteria, or whether it's more of an adaptive response involving memory cells, and they interact with all types. And so for many years, nadocromil, the classic mast cell stabilizer, has been used to prevent further mast cell degranulation, to prevent secretion of the different cytokines and chemokines, etc., that mast cells make. More recent classes of drugs also have the additional properties of inhibiting histamine from binding to one of its two receptors, the H1 or H2. And so these drugs have added extra effects which are considered to be highly beneficial. However, we looked in a human mast model. These are cord blood mast cells that we bought. We expanded these cells over a period of up to 12 weeks, and you generate many millions of absolutely pure stem cell factor positive mast cells, which secrete histamine. The picture at the top here in A, these are resting unstimulated cells, not stained, so just to show you the large cytoplasm where they're storing their potential secreted cytokines. Then in B, they're stained with a marker. In this case, we chose tryptase because it's expressed by most of the cells in the culture. Some of the cells at the resting stage have high levels of tryptase, others not so high. But then the lower panel indicates a culture that was cross-linked to degranulate, and you see that some of the cells express extremely high concentrations, high density of tryptase, highlighted with the arrow. Others secrete the tryptase, but the good news is these cells don't die. They go on to reform, resynthesize their histamine, etc., and go on to fight another day. But when we looked at these cultures in the presence of a number of different anti-allergic drugs, including the control here is nadocromil down at the bottom, which is just a stabilizer. If you look at all these other cytokine profiles, you can see that the drugs were very effective in inhibiting many of the secreted cytokines and chemokines. But the key message here was that not all of these drugs inhibited the same types of cytokines or chemokines. And this, we feel, is the classic immunological explanation as to why some drugs work better for some patients whilst others are better for others. And maybe you have to mix your antihistamines around a little bit in order to get a full effect. Now, moving on rapidly to the more clinically severe forms of ocular allergy. These forms, either VKC, which tends to affect children and young adults, and is highly associated with atopy. There's a seasonal worsening, as we mentioned before. Then looking at the adult version, the AKC, and you'll hear all about it later. But essentially, when you look at the tissues of these patients, there are huge infiltrations of CD4 positive T cells, eosinophils. The mast cells are there, yes, they're activated, but there's an extra layer of inflammation that occurs in the severe forms of disease. And this panel on the right here, the left-hand picture just shows a normal tissue section where the red cells are just a few baseline sentinel cells, T cells, sitting just under the epithelial layer, whereas on the right, at a higher power, the brown cells are very much infiltrating. These are activated CD4 T cells. And I think the key thing to remember here is that VKC and AKC, mast cell inhibitors alone, just don't control the inflammation. We need much more than that, as I'm sure everybody is aware on this call. So before we launch into sort of T cell cytokines, we need to bear in mind that these T cell subsets that exist in the tissues, these T cell subsets very often regulate each other. So the Th2 cells, which is highlighted with the IL-4 arrow here, they express GATA3, that's their signature transcription factor, and they make a lot of different Th2 cytokines. These cells predominate at mucosal sites. However, they not only mediate their functions, but at the meantime, they inhibit Th1 and Th17 cells. So in fact, they're completely dominating, and they're kind of keeping these other cells in check. Not only that, but at the bottom here, you have these FOXP3 expressing regulatory T cells. They secrete cytokines like IL-10, TGF-beta, which are also inhibitory for T cell responses. These regulatory cells are the ones that we're trying to encourage to come into an inflammatory response, to switch off the T cell response altogether. But in this case, it's the Th2s themselves that seem to be doing a pretty good job of keeping Th1 and Th17 in check. So this is known from a variety of different T cell mediated diseases that these antagonisms occur. What we are actually aiming for are the new sorts of treatments on the right here, which specifically target particular cytokines and receptors to switch them off. And by understanding the different cytokine pathways that are involved in the different diseases, hopefully we can identify the pathways that need to be turned off in ocular allergy. So that's the ultimate goal. How do we get about that? So way back, many, many years ago, we had been staining conjunctival tissue sections looking for T cell cytokine expression. And we also raised T cell lines from the biopsies themselves, fresh biopsies, and looked at their cytokine profiles. And they were just non-specifically expanded cells. So there was nothing cloned about this, but eventually we were able to sort of see a profile emerging where the conjunctival T cell lines raised from VKC patients predominantly secreted Th2 cytokines. In those days, it was IL-5 and IL-13 that we were looking at. And these are the blood levels in white, the white bars from the same patients. But what we did see with AKC, which is the top graph here, was that not only did we pick up the predictable Th2 cytokines, which one would expect from a mucosal site, we also saw significant increases in Th1 interferon gamma. And this was the first time that we really had an idea that AKC is much more of an autoimmune-like disease than an allergic disease. Not only that, but we went on to identify expression of Th17 cells. On the panel on the left here, you can see the arrows. These are CD4 positive ROR gamma T, which is a transcription factor expressed by Th17 cells. And the double positives are present within the tissue. The top right picture here with a single arrow, this is IL-17 expression. And look at the epithelial cells here at the conjunctival interface, where you have very high levels of IL-17 binding to the conjunctival cells. And then you can also see these cells in tear samples extracted from patients with this was a study with VKC, where we looked at 12 different tear samples, and we did flow cytometry to look for the co-expression of the transcription factors. And we found that patients either had Th2 or Th17 cells in their tears, but rarely did these two coexist. So we were beginning to get an idea that there's a complicated mix or complex mix of T cell subsets at the ocular surface. These sections are just to illustrate further that when you look for a typical Th2 cytokine, in this case IL-13, you can see that in patients with the mild seasonal form of allergic conjunctivitis, the staining was very muted. These goblet cells in brown here, they're quite sticky because of the mucins they're secreting, so antibodies do tend to stick to them non-specifically. However, on the right, you can see the VKC cross-section where the epithelial layer is absolutely screaming with IL-13 expression. That's because the IL-13 is bound to the epithelial surface. And the bottom left here is showing an AKC panel, a section rather, where you can actually pick out individual immune cells with expressing IL-13. So it's very much a cytokine of interest. It is present at the ocular surface. And when you look at patients with, for example, in the dermatology world, IL-13, the role of IL-13 is several-fold. It's involved in interacting with a number of different key cells. But I think in the case of ocular allergy, the fibroblasts would be an obvious target. We see a lot of collagen deposition by conjunctival fibroblasts, which is enhanced in VKC biopsies. You see a lot of MMP deposition. And again, it is likely that this is due to IL-13, although not confirmed. I think what was very nice was that we also saw by in situ hybridization that only in the AKC conjunctival sections did you see significant expression of interferon gamma. So AKC is different to VKC.
We're above 10 minutes now. So if we can...
Yes, I'm on my final bit. This is just a recent paper by in Allergy, which discusses the epithelial barrier theory to allergy and allergic diseases. And I think very nicely ties in with what's going on at the ocular surface, where you do see changes occurring to the epithelial cells, particularly in more severe forms of disease. So I'm just going to another very recent paper by the Leonardi group, where they've started to look by genomics to see which genes are upregulated in more severe forms of VKC. So I'm going to summarize here. This is a summary of the various different cell types that have been shown scientifically to be present, to be activated, secreting the various cytokines, and it is different depending on the clinical severity of disease. And I'd like to thank everyone for their attention, particularly the Ocular Allergy Working Group and the organizers of the meeting. And that's my talk finished. Thank you.
Thank you so much, Virginia. I think that was a great beginning to our session. I just have a question, which all of us as clinicians do have. Is there any difference between the mild and the severe versions that we see clinically when we look at them immunologically?
The mild and severe
versions of vernal keratoconjunctivitis or the atopic conjunctivitis?
Yes. So I think, sorry, that has to do with the degree of activation of the cells. So I think in the clinically active forms, your T cells are more activated, the eosinophils are firing, the mast cells will be continuously degranulating. And so comparing mild with severe forms of VKC, I think it's important to bear in mind that the severe forms, the active disease, they are needing more sort of serious treatment than just, say, the baseline mast cell inhibitors.
Okay, great. So you're basically saying that they are much more activated in the severe forms than the milder versions.
Yes, yes.
So I have another question for Gonzalo. Gonzalo, do you think there is an overlap immunologically when we look at the systemic form of the disease and the ocular form? Like, you know, when you have a child with asthma along with or allergic rhinitis with an AKC or a VKC component, do you think there is an immunologic overlap or?
Yes, I agree completely. I think there is an overlap and it needs to be addressed in a systemic way. That's very important.
Serge, do you want to add something?
Yeah, excellent talk, Virginia. I wonder, you know, there are side effects of dupilumab therapy, which is an anti-IL-4, anti-IL-13, and the clinical picture of these patients looks like AKC. I mean, they have conjunctivitis, limbal edema, no giant papillae, but do you have any idea of the mechanism? There are some studies that show that there is an the Th1 pathway which is activated. But in your mind, do you have any opinion?
Well, that's why nowadays, when we talk about this, we have to talk about the balance between these different subsets. We know that Th17 cells are there and Th1. And if you are blocking the Th2 pathway, you're allowing these other, in a way, more serious subsets of cells to exist. You're removing the regulation of those cells. Unfortunately, I haven't had the opportunity to look at patients receiving dupilumab who have this resulting eye problem, but it would not surprise me at all that the balance is disturbed, and that is why in some patients there is this emergence of an inflammation as a result.
Okay. Okay, thank you so much. I think we have probably to move on. Dr. now Shweta Agarwal will talk about the difference between the severe and moderate forms of VKC. Is it correct?
Yeah, but I think there is some problem in me sharing the slides. So shall we move to the third speaker, and probably I will log in and log out and log in again. So let's move to the third speaker so that we don't waste time. And I will try and see what's happening to my slides.
Our third speaker is Dr. Vibha Sharma. Ma'am's going to talk about evaluating pediatric allergies and allergomatic roadmap.
Thank you very much for the kind introduction. Whilst I'm loading my slides up, I would like to say a very, very happy Republic, 76th Republic Day for India. So I was banking on the wisdom that Shweta would have done with her slides. I hope you can see my slide and it's in a presenter mode. Lovely. So I was asked to talk about evaluating pediatric ocular allergies and specifically an algorithmic roadmap. We've got a limited amount of time, but what I thought I'd do is take a pragmatic approach because there aren't any diagnostic specific criteria for the severe forms of the allergic eye disease. There are loads of pathognomonic signs and symptoms that people see and make a diagnosis. And there's tons of literature on grading the severity of the disease and escalating treatment strategies. But just for evaluation of pediatric ocular allergy, this topic was rather entertaining and an interesting one for me. So if I could just try and see these are my disclosures. I have no conflict of interest in relation to this presentation today. So in pediatrics, the allergic conjunctivitis is actually quite a big spectrum. And as you will see, we've got a big wide base at the bottom, which is seasonal or perennial allergic conjunctivitis. In the global population, around 60% of individuals will identify themselves as allergic individuals. And of these, majority, 90% are seasonal allergic conjunctivitis. These are milder cases, and they would either not need any treatment or they would buy over-the-counter treatments to allay their symptoms. They're generally short-lasting and they might not need evaluation because they do not even present to the medical faculty. Perennial allergic rhinitis may be a little bit more persistent and they may therefore present. So they may be a little bit more amenable to investigations. The other two groups, vernal and atopic keratoconjunctivitis, are the more severe, more calcitrant groups where treatment in conventional means may not be very effective, and therefore they certainly do present to the medical faculties for investigations. Now, the interesting thing is that with vernal keratoconjunctivitis, there is a spread across the world and it varies, and that brings into focus what would be the cofactors in such diseases occurring. And so in Scandinavian countries, the incidence may be as low as 27 cases per 10,000 population, whereas in India, the incidence is quite high. And in fact, one of the publications was talking about 10% of the ocular allergy being vernal keratoconjunctivitis. So dependent on which part of the globe you are, your investigation strategies may vary a little bit, but let's focus on VKC and AKC as areas where we may be investigating to give ourselves a level playing field across the globe. And so, yes, we have ophthalmologists who will be investigating, but as we've heard, these are sometimes multi-system disorders. And it is, in fact, in VKC and AKC, it is quite commonly the case that there are other system disorders such as rhinitis, asthma, and eczema that is coexistent. And so a multidisciplinary approach involving an allergist is quite helpful. This is a slide to just give you an overview of what the differences are between vernal and atopic. And I'm aware that Shweta is going to be logging in, so I will not steal her thunder and leave it to her discussion. But suffice it to say that there is an age distribution. So prepubescent individuals are more affected by vernal keratoconjunctivitis. And whilst you do see atopic keratoconjunctivitis in pediatrics, it is more a disease which is persistent into adulthood and can even start in adulthood. So my algorithmic roadmap is going to be rather pragmatic. I will start with a very straightforward seasonal allergic conjunctivitis, a person who's got mild symptoms, who is possibly using some treatment, maybe not all the time, and is affected maybe 1 or 2 days in a year with symptoms that require treatment. These people will not come to your clinics and therefore possibly not investigated. But if you've got somebody who is affected like perennial symptoms, who are coming to consultation, then you will look for investigation. And the eye surgeons, predominantly people in this call, will be apt at looking at these under slit lamp examination and undertake the investigations appropriately. So this is my roadmap, and I'll come back to you in the conclusion slide once again to elaborate a little bit more. So the tests. I will not focus on the tests the ophthalmologists will do. So keeping it a little bit general, in terms of allergy investigations, you can do it by skin prick tests or blood tests looking at specific IgE testing. The lovely tests that Virginia has talked about are unfortunately not available to us in the clinical field. The other pragmatic test that can be undertaken is conjunctival allergen provocation test, but that is unfortunately not available across the world also in all allergy centers. So the skin prick and the blood tests predominantly interrogate the sensitization, which is IgE mediated, and taking into account the response of a provocation test, one can understand not just the sensitization, but also the allergy, the allergic manifestation of such a sensitization. And based on this, collectively between the eye surgeons and in allergy team at Manchester, we will come into conclusions and advice on specific avoidance and specific immunotherapy. These tests are not useful for giant papillary conjunctivitis, which would be the sort of thing that you will see with corneal foreign bodies, such as contact lens wearing, or contact dermatoconjunctivitis, which is really related to the chronic use of eye drops, for example, glaucoma eye drops, etc. And then there are some tests which are really not in clinical routine practice, but are available to researchers, for example, in vivo confocal corneal microscopy. So let's take them in turns. Sensitization can be elicited by skin prick test or by blood tests. And those of us who are not aware of these tests, the skin prick test is a very straightforward, immediate type test. It is got a few drawbacks. So the drawbacks being that it can be dependent on the observer, and also it can be dependent on the sorts of lancets you're using, or the dilutions that you're using, or the allergen production that has been put into place when you're using those bottles that you're using for your testing. And the other thing that is quite important is the background comorbidities, which will drive the medication the patient may be taking. So if somebody is on oral steroids or antihistamine, then you will have a diminution in the sensitization response. Now that is something that is sidelined by taking a blood test, because you're looking at the cellular level, and therefore that is the concerns about the co-medication is removed. However, it takes a little longer for the blood test to come, and these tests are becoming more and more sophisticated nowadays. You're looking more at component specific to an allergen, which is relevant to an allergic sensitization. Now, it's important to highlight that in 50% of cases of VKC, you may not be able to find any sensitization. And in these cases, when it comes to advice for allergen avoidance and immunotherapy, then it becomes quite a challenge. So allergen provocation, which is done in other fields such as drug allergies and in food allergies, there is an equivalent of it in eye allergy, conjunctival provocation test. And in this, what one would do is instill the allergen into the inferotemporal area of the eye. So in this case, the left eye is being instilled with a placebo, and the right eye has been challenged with the allergen, and it shows a response here. And based on the response, there is a grading criteria which will tell you the severity of the response that you see on the provocation. There are researchers in Germany who have tried to use AI and make it easier so that there is validation using a software where the nuances of the slight changes that may be overlooked by a human eye could also be accounted for. So going on to the research based testing, which is in vivo confocal imaging, which has been used in other disorders of the eye, as the ophthalmologists will be well aware. Andrea in 2012 published his findings that when children were affected by VKC, the confocal imaging showed changes in the cornea, and these were high reflectivity, increased cell diameter in the superficial and the basal epithelium, and the nerve cells were also changed, and there was a reduction in the keratocyte density in the anterior stroma. 3 years later, another group published their findings confirming changes, but they also came up with a very interesting finding. So traditionally, it was felt that the VKC would either be a palpebral or a limbal presentation, or maybe a mixed presentation. And this group of researchers found that there is a separate, just corneal form. And what they found was that in this group, there was intense photophobia, and the alterations in the pathology or the findings were only within the cornea, picked up by confocal microscopy. So this was changing the face of the pathology itself. So in summary, bringing all this together, if somebody has mild presentation, then a history and examination would suffice, barring those where you have persistent symptoms or they're impacting on the quality of life, and you can undertake investigations, as we highlighted previously, of the skin, the blood, or the challenges. For those who've got moderate to severe intensity, allergy tests would be a good idea. And for these, the tests will help in specific avoidance and specific immunotherapy guidance. And then those who are affected either by mild or by moderate or severe cases and are of the inclination that they would want to go towards contribution to research, they could then be evaluated by tests that are currently not in clinical practice, such as the confocal microscopy. So we have heard about lots of other tests, the cytokines, the chemokines, and these are also evaluated in research practices, but they are not helping us in managing or specific interventions. Similarly, there are interventions of impression cytology, and they also have not been yet published with interventions specific to their management. And so just keeping it very straight and simple, allergy investigations for severe and moderate groups. And with that, I'll conclude. Thank you, and I'll be happy to take any questions.
Thank you so much, Vibha. That was really, really great. So my question is there a way in which, or a different technique that you use to diagnose patients who are non-IgE mediated allergies? Like, does the screen test and the blood test do still hold value in those patients? And what is pheno test about? I think I'm just bouncing too many questions, but there are a lot of allergists in India where, when we send them, they do the pheno test. So a couple of questions too.
Very helpful questions. So pheno is exhaled fractional nitric oxide, and that is elevated in individuals who have got a high level of ongoing active burden of allergic disease in their airway. So in individuals who've got uncontrolled asthma or those who've got uncontrolled allergic rhinitis, you may have an elevated level of pheno. And somebody may be able to use it as a surrogate, but you will not find that it is a good reflection of the allergic eye disease, because the allergic eye disease goes hand in hand with rhinitis. The phraseology is usually rhinoconjunctivitis, and I had to train myself to not use rhinitis in the presentation today. It goes so equally. People will be managing rhinitis alongside of conjunctivitis, and therefore they will use pheno as a surrogate for the inflammation and allergic inflammation in the nose and the airway, the lower airway, the asthma. I don't think it will be a clear indication of managing a allergic eye disease. The second thing was about the T2 type phenomena. So it is the non-IgE mediated responses. And that is quite an interesting and a challenging situation, because we don't have a direct measure So we don't have a good test for T cell function in the clinical practice that would help us evaluate those T cells easily. Now, in the general allergy, there is an evaluating or an evolving test that is evaluating the T cell function. And it is doing it by direct challenge of the lymphocyte by the offending allergen. And it is coming across as lymphocyte transformation test. And so this test this is still a research tool, and we're using it increasingly in drug allergy evaluation. So if somebody was thought to have a delayed type drug allergy, then we can do a lymphocyte transformation. So it's an in vitro test. You take a blood sample, you would extract the lymphocytes from that person, and you will take the offending drug and you will interact those, and then you will see the responses, the cytokines that are created from that, and a measure of the released cytokines and chemokines will give you a response on whether or not such a trigger was causing a lymphocyte transformation. So unfortunately, for the delayed ones, it is not a very good measure. There are some groups who will evaluate this by using chambers. So in people who've got, say, house dust mite related symptoms, and they are not showing an IgE response, apart from the conjunctival provocation test, they could be sat in a room where you've got lamellar air flow and you're almost like allergen free. And then a tiny amount of the allergen will be introduced into the air, and that will come into contact with the conjunctiva and the mucosal surface of the nose. And so some of the individuals will have an immediate response whilst they're sat, some will have a response after they come out of the chamber, and some will have a day or two later. And that can be monitored, and you can come out with a bit of a response, and that would be a delayed response. But it is a laborious process, and it is not, again, available in all centers. So you've got to find the space where you can do the air chamber challenge.
Thank you so much, Vibha. So what I have understood is, please correct me if I'm wrong, that the skin test and the blood tests really work primarily for the IgE mediated form. So if you have the serum IgE, which is normal, then there is no point of going ahead with that. Am I correct? Or is my understanding flawed?
So the IgE level itself is an indicator of atopy. So in a person who's got eczema or asthma, you can have very high levels of immunoglobulin E levels. And therefore, it has an impact on the specific IgE level to a certain allergen. So you may find that the IgE level normally would be in the range of 0 to maybe 300, but in an atopic individual, you might find that it was actually highly elevated at 3,000, 5,000, 15,000 even. And that has an impact on the specific IgE. So you can have non-specific elevated levels, and that is not a very good way of assessing it. So if you're looking at an allergen, which is an aeroallergen, and you're suspecting that somebody's got rhinitis, then you will do the tests only specific to the inhalant allergens, particularly in a person with eczema or asthma, because doing say the test for blood, for milk, or for egg or peanut allergy, that is an irrelevant investigation. So the IgE has to be targeted for the allergen that you're looking for. Now, if you found that you've done the test for specific IgE to house dust mite and you found no response to it, then that doesn't mean, if you're clinically suspecting that the person has got all year round allergy, they don't have a dog or a cat or a mold problem at home, and you're suspecting that it is related to house dust mite, then that may be where the next step of investigation, which is the conjunctival provocation test, may come in handy. Or if you've got access to an air chamber provocation, then that may be a useful thing to do. Does that make it clearer?
Absolutely. Thank you so much.
No problem.
Okay. Excellent. Thank you very much, Veba, for your excellent presentation. I think we have to move on because we are already running late. We have almost 15 minutes delay. So please, Professor Shweta Agarwal, what is your revisited VKC classification? Oh, you are muted?
Yes.
Okay.
So good afternoon, everybody. Well, I'll be taking through the new classification of vernal keratoconjunctivitis and try to bridge the gaps for a better outcome. Yeah. So no financial closures or conflict of interest. Well, we all know that VKC is a bilateral recurrent ocular allergy with a male predominance and an onset primarily in childhood. There are multiple grading systems for VKC that do exist, but all of them basically grade the severity of the disease on the disease activity, so the disease has to be active, and the signs and symptoms that the patients present with. They suggest the treatment based on this grading. Well, we do have some lacunae in the current classification, and that is primarily the inability to grade and manage these patients in the quiescent phase. So if you have a patient presenting to us with an absence of activity, we really don't know which grade do we put them in. Also, none of the current classifications include the telltale signs of previous disease, like the shield ulcer or a limbal stem cell deficiency or a keratoconus with intermittent symptoms. Now, why is this necessary? Well, we do have studies which have shown that an ongoing subclinical inflammatory process does occur even in the quiescent stage. So we do have an altered Ter cytokine profile, and confocal microscopy has shown us that there is an increased density of Langerhans cells in the quiet stage. With the disease chronicity, the clinical picture gets altered. We have altered corneal nerves in chronic VKC. There could be an associated dry eye. The severe punctate keratitis that we are seeing in a child with VKC could be just related to the dryness. The chronic inflammation interferes with leucine production, and thus there could be a significant sign-symptom discord. There is, therefore, a need to look beyond just the frequency of symptoms and active signs for grading VKC. Well, the aim of our study was to propose and validate a universal grading system in which, in addition to the presenting symptoms and signs, we would include the telltale signs of previous corneal involvement and propose a treatment guideline. Well, this was a retrospective study which was done only with corneal specialists evaluating patients, and the last visit was considered for recording the signs and symptoms. We have graded it as mild, where you have mild seasonal symptoms with or without signs, moderate, where the symptoms become persistent, there could be activity or no, and they usually have no corneal involvement at this stage. When the disease becomes severe, you have chronic persistent symptoms with or without intermittent signs, but with corneal involvement, or they could be asymptomatic to mild symptoms with corneal telltale signs. The very severe versions have chronic persistent symptoms with corneal involvement or telltale signs, or they could be just asymptomatic with complications. Well, we all know the active signs of the disease. When it comes to the corneal telltale signs, it is usually a corneal scar indicating a resolved shield ulcer. The complications would be the limbal stem cell deficiency, keratoconus, steroid-induced glaucoma, or cataract. The symptoms were defined as persistent if the frequency was more than 4 per year, and chronic persistent if it was less than 1 month of symptom-free period. Well, of the 13,000 children patients who presented with ocular allergy, 1,096 patients were included in the study, was diagnosed with VKC. 51% of them had acquired disease, and 51% had the perennial form of the disease. Well, 50% of them had itching as the presenting symptom, and almost 11% were asymptomatic at the time of presentation. Asthma was the most common underlying allergy, with 5% of them presenting with it, followed by the atopic dermatitis. Grade 4 was the most common grading, irrespective of gender and age. Well, more than one complication was present in almost 13% of patients. And when we talk about a significant association, well, it was the duration of the disease, that is, longer the disease present, the higher was the risk of complication. and a presence of systemic allergy was another risk factor for complications. Now, when we look at the treatment that these patients were on at presentation that initiated somewhere else, only 30 patients were on some kind of topical immunosuppressive therapy. However, 9 were on systemic immunosuppressants and steroids. However, at last visit, after the treatment received at our center, almost 326 were on topical immunosuppressants, with only 1 being on systemic. Now, this study highlighted that more than 50% of the patients had the chronic or persistent form of a disease, and there is definitely a sign-symptom discord that we see in a group of these patients. There is a high incidence of both treatment and disease-related complications. Now, when we look at the different classifications that we have, this Perevicia et al. In 2006, they graded disease based on 2 severity scales. However, the corneal involvement was not included, and this also needed an active sign to classify or grade the disease. Bonine et al. Came a step forward, and they graded it based upon the signs and symptoms and the frequency of disease, and they also proposed a treatment algorithm. However, this too needs active signs for grading. It does not include the complications and also does not recommend the referral time for an oral immunosuppressive or referral to an allergy specialist. Boakley et al. Moved a step forward and included the limbal stem cell deficiency as one of the complications. However, it was only that was a part, none of the other complications were included. And this too needed the disease to be active at presentation. So the universal grading system that we propose takes into account the telltale signs of previous involvement and complications. So irrespective of the disease activity, the disease severity increases with the presence of complications or corneal telltale signs is what we concluded from the study. Also, the treatment algorithm includes the role of immunomodulators and the referral to allergy specialists, as we also realize that the presence of systemic allergy is what really increases the risk of severe disease. I'm very happy and glad to share that this was the paper which was awarded the best paper in the last EAACI held in Spain. And in fact, it has been accepted as a publication now in British Journal of Ophthalmology. So the treatment guidelines that we proposed was, in the milder versions, we can continue with the seasonal use of dual-acting anti-allergics and antihistaminics. The moderate version would have the perennial dual-acting anti-allergics along with on and off low-dose steroids during the active phase of the disease. And once the symptoms become persistent, you could refer the patient to an allergy specialist. Once the disease becomes severe, in addition to all of the above, start using the topical immunomodulator like the tacrolimus or cyclosporin, whichever is available in your country. Surgical intervention, if required, for the giant papillae or shield ulcer, and referral to the allergy specialist. The very severe ones, you need all of the above. Step up the concentration of the topical immunomodulator to the maximum that is available in your terrain. Pulse dose of high dose potency topical steroids or a short course of oral steroids. Surgical intervention wherever required for associated complications, and do refer to the allergy specialist. To conclude, the new proposed grading system takes into consideration the varied clinical presentation, which is an inherent feature of vernal keratoconjunctivitis. It focuses on the telltale signs and complications and bridges the concerns present due to the sign-symptom discord. It also proposes the treatment guidelines based on the improved understanding of the etiopathogenesis. Thank you.
Okay, excellent. Thank you very much, Professor Agarwal, for this new classification. So it's very interesting because it's true that in the current classifications there are no considerations about the scars and about keratoconus or other corneal involvement. So I have one question about the cyclosporin and the immunomodulator. So in your series, finally at the entry, when they entered the study, very few were on topical immunomodulators. How do you explain this?
So exactly, that's what. So the problem is, again, awareness. So these were patients who were treated elsewhere and presented to us. A lot of them were just using on and off topical steroids and were not probably prescribed the immunomodulators, which is the need. And as I said, most of the current classifications don't really give us the timeline or guidance about introduction of the topical immunomodulators in the treatment. So I really can't explain as to why they were not started outside, but I think probably these are the two reasons that could explain as to, why they were not started elsewhere. Probably
So
Dr. Vanity, you want to add on this? Like, why do you think that locals don't start?
Hello.
Yeah, we can hear you.
Yeah, can you just repeat your question? My net is a little unstable. I didn't get your full
So
question.
Dr. Serge had a very valid question, which we also were wondering that in the series that we did at presentation, a lot of the patients who presented were not on topical immunomodulators. The treatment was initiated elsewhere. So what I was trying to tell him is a lot of them were on topical steroids on and off, and the proposed guidelines for now that is available for treatment don't really give us a timeline or a guidance as to when the topical immunomodulator should be introduced.
I think I will totally agree with you on that. If you look at the severity of dry eye level disease, level 1, level 2, level 3, level 4, there is a very well-defined protocol of when do you add the step ladder kind of treatment with lubricants, anti-inflammatories. And I think there is a lacunae in terms of describing a similar form of a treatment for VKC. So by and large, it still stays within the purview of individual clinicians who use their own parameters for the treatment management. And as rightly pointed out, many still would want to control with acute anti-inflammatory agents, and that's where the abuse of steroids and the secondary complications because of steroids occupy a large amount of the comorbidities which exist in allergic eye disease vis-a-vis the primary disease itself. I think the bracket of patients who have a very severe primary disease is much lesser in percentage vis-a-vis looking at the comorbidities which are actually complicating the disease, especially in a country like India. And in tertiary care centers, I think I would agree, Shweta, where you and I would probably see a very, very high amount of secondary ocular comorbidities because of steroid abuse. So I think this is perhaps because of a lack of a uniform protocol of introducing immunomodulator therapy in the management of disease, and people, I think, are probably not properly guided or not properly grounded in terms of when they need to start their immunomodulators.
Okay, and can there be also a problem of access to cyclosporin in India, or?
No, it's very freely available, Serge. In fact, we have a lot of cheaper versions as well. And tacrolimus ointment is very freely. So there are very few places where you have the tacrolimus ointment available. And that's very readily available in our country, and it's not expensive.
Yeah, I
tacrolimus ointment is extremely easily available, and it's very cheap.
And it's there in 2%, 0.03 and 1%. And for those, especially in pediatric age groups, which do not tolerate topical usage, a simple over the skin application of the lids is more than enough to control a large amounts of even moderate to severe eye disease, where the severity definitely does go down, and several times you don't need to move into more aggressive forms of injections for these if they are regular and compliant with a topical usage or over the skin applications. And I think we have recently published a study in Konya as well, and we did find significant clear levels of tacrolimus for over the skin applications of tacrolimus eye ointments. Yeah, so it's a very easy therapy. It's probably the awareness or the readiness to start immunomodulator therapy early on and keep them on for a period of time. I think a course needs to stay on for at least 4 months, and how long, the longer they will need to continue is going to depend upon the severity level which affects the ocular surface disease for a given patient.
So thank you very much. Yeah.
If I may add a point to what Dr. Vanati and Dr. Shweta is trying to raise specifically for our geographical area, probably the point that we do not know exactly what time to introduce the immunosuppression. It is also the regimen, which is not very clear for which level, for how long would you be increasing or decreasing the steroids or the topical immunosuppression. That also makes the patient go from one clinic to another when they do not get a relief. So I guess that is also something probably we would be looking forward to, addition to this new classification that Dr. Shweta has introduced. Thank you.
I think in view of time, let's move to the next speaker. So we
Yes.
have Dr. Neeraj with us, a renowned allergist from Gangaram Hospital, Delhi, and he'll be taking us through the biologics. Neeraj?
Hi, good afternoon, everyone, and thank you for the opportunity. So, I will be speaking mainly about immunotherapy and biologics, and the previous speaker, especially Virginia and Vibha, they both have made my job very easy, that they have actually set the stage. So I do not have any disclosures or no conflict of interest. So I will be discussing my topic under the following headings: burden of the disease, allergic response, available therapies, and the newer tools in the form of immunotherapy and biologics, and current recommendations. So we understand that allergic conjunctivitis itself is somewhere varied in prevalence with 10 to 30% in heterogeneous population, with certain predisposing factors like genetics, inflammation, atopy, and pollution. And itching, eye rubbing are frequent, with several ocular comorbidities are there, as Shweta has already mentioned about corneal morbidities along with visual morbidities. So with this, a broad classification, we understand that the most common presentations are either seasonal allergic rhinitis or perennial allergic rhinitis, but we also see sometimes atopic keratoconjunctivitis, vernal keratoconjunctivitis, and giant papillary conjunctivitis. This is just a brief to mention about the launch of allergic response so that I can build up from there to immunotherapy. We understand that as the allergen center, so they are taken up by the dendritic cells, and then they are presented to CD4 plus naive T cell. And with the help of this interleukin 4, they actually, you can say, like convert to CD4 plus Th2 cell, and this Th2 pathway ultimately releases certain interleukins, and these interleukins are mainly responsible for your Th2 mediated allergic phenomena. So usually this Th2 pathway, the most common interleukins are IL4, IL13, which stimulate B cells, and ultimately IgE production happens. And this IgE ultimately get bind to the basophils, eosinophils, and the mast cells, and they remain in the circulation and wait for the re-exposure of allergen to happen. Whenever the re-exposure happens, then at that time, the already pre-formed mediators in the mast cell, they are released, and then the symptoms like itching and other manifestations come. But it is not only the single interleukin. There are certain other interleukins which are also playing part, like IL5 has already been mentioned, and which is actually having the eosinophilic inflammation as a predominant role, and which is sometimes picked up by pheno in the airways. And then IL4 also has a autocrine role also, that it stimulates the Th2 by itself. And then there are certain other interleukins which are also going on, like IL9 and others. So with the available therapies, well, I will not go in detail. So with the available therapies, as per the grading or the severity of the allergic eye, you people use them. But the treatment of comorbid conditions like allergic rhinitis, asthma, and atopic dermatitis, along with immunotherapy, also needed in certain selected situations. So what allergen-specific immunotherapy does? So as I have already mentioned in the previous slide, that how this Th2 pathway is triggered. So this allergen-specific immunotherapy, where it works is, it works at the bottom line, at the just the precursor cell, that is CD4 plus T cell. And what it does is that it stimulates the T regulatory cell. Ultimately, this T regulatory cell blocks certain production of all the interleukins which are mediated, like IL4, IL5, and all others. So certain protective interleukins like IL10, IL35, and TGF beta, they are more produced, and they ultimately blocks the rest of the pathway. The rest of the pathway, which I just mentioned about the effect of the mast cell, basophil, and eosinophil, and these all are blocked. And it is said that it changes the milieu or changes the balance from Th2 to Th1. So it is basically the conversion of or reduction of Th2 pathway, and hence there is an unadded elevation of Th1 pathway. This is a brief classification based upon the clinical features of major ocular allergy syndrome, in which we see that the seasonal allergic rhinitis and perennial allergic rhinitis are predominantly IgE mediated. When they are IgE mediated, and I mentioned you that this allergen immunotherapy is mainly working on the IgE mediated phenomena, and these are IgE mediated, so that is why allergen immunotherapy is working best for these conditions. But the conditions like vernal keratoconjunctivitis or atopic keratoconjunctivitis, here the pathophysiology is mixed. So it has been postulated that it could be allergen driven, IgE mediated, and there are certain non-IG or para-IG mediated mechanisms are also going on. So here immunotherapy is not, you can say, like working that good, and the results are really the mixed results. And then there are other conditions like non-IG mediated in which immunotherapy is totally not recommended. There are not many papers and you can say like recommendations which are there and which tell us that yes, immunotherapy is usually very good, but this immunotherapy has been mainly useful in seasonal and the perennial allergic rhinitis or allergic rhinoconjunctivitis, with both short-term benefits as well as for the long-term benefits. These are there. So this is one paper which has been recently produced in September 2024 from India, and this is a meta-analysis in which they have combined several studies, and they have come out that yes, it is useful, but mainly in the seasonal and the perennial one. There are certain risk factors for adverse systemic reactions during immunotherapy. So suppose if somebody who starts in uncontrolled asthma should not be started, so the disease should be controlled. History of prior subcutaneous injection related systemic reactions. So if there is a previous reaction, then it should not be given. High degree of sensitization, so it should be refrained at that time. SCIT injection during the active season. That means if somebody who is allergic to a particular pollen, then it is considered that it should not be started in that particular season. It should be started either pre-seasonal or probably at the resting phase of the time. Or if somebody who is having an underlying mast cell activation, then it should not be started in these conditions. Active infection is another risk factor, so it should not be started during the time of active infection. And then the dose escalation needs to be taken care of. If the person is on the drugs like beta blockers, then at that time we need to be cautious, and the person is means like after high intensity physical exercise, we need to take a certain time duration gap, and then only the immunotherapy should be given. So this is EAACI position paper which was published in 2019 for management of ocular allergy, in which Dr. Vibha was also one of the author there, and Virginia as well. So they all are saying that allergen immunotherapy is effective in achieving the clinically important short-term improvement in symptom score, medication score, and combined scores. So, and then they have seen the results with the subcutaneous immunotherapy and sublingual, and they have particularly highlighted that yes, sublingual immunotherapy is definitely useful in allergic rhinoconjunctivitis, especially seasonal and perennial. But there are certain studies in this paper which also says that the strength of evidence is low for, especially for the subcutaneous one as compared to the sublingual. So allergen-specific immunotherapy we need to consider when moderate to severe symptoms are there, which are strongly suggestive of allergic rhinoconjunctivitis, which are actually affecting the quality of life or sleep, despite adequate pharmacotherapy and avoidance strategies, and evidence of sensitization to one or more clinically relevant allergens are there. Majority of the time, the allergen-specific immunotherapy has been prescribed in allergic eye, in dust mite or pollen allergies. So additional points to consider: conjunctival allergen provocation test may be helpful in detecting most relevant allergen if we are in a dilemma after doing either skin prick or specific IG in an index patient. And AIT should be considered when the disease is relatively controlled, rather than we should think about that the disease is very in the advanced stage. And it can also help in halting, or at least you can say like reducing the pace of the atopic march, thus potential prevention of asthma. So it has been seen that there are certain clinical outcomes, and then newer developments of allergen immunotherapies are now coming up with some safer routes, and ultimately they actually improve the quality of life, and symptom and medication score is reduced. So recommendations: it may be considered in cases of failure of first-line treatment to modify the natural course of ocular allergy disease, and it is important that it has to be IgE-mediated hypersensitivity and symptoms are controlled. So seasonal, that is grass pollen, and perennial, mainly the dust mite allergens, which has been maximally seen, maximally studied, and maximally recommended. Slit sublingual immunotherapy is effective in reducing total and individual ocular scores. But now comes a question about vernal keratoconjunctivitis and atopic keratoconjunctivitis, where the pathophysiology is mainly mixed. Here, the studies are not conclusive. So that's why I told you that's a mixed result, and we need to go with the case-to-case based assessment. Last few slides about the biologics. So status of biologics and ocular allergy. So this is once again the same pathophysiology diagram, in which the complex diagram is just showing that allergen is entering, and then it is presented to the dendritic cells, and then the Th2 pathway is getting triggered. Lot many interleukins which are going on. This is IgE mediated pathway, and simultaneously another IgE independent pathway which is also going on. So what these biologics are doing, so different biologics are actually countering the effect of different interleukins. If you can just see that the blue one, like omalizumab, this is mainly against IgE. If you just see the dupilumab, this is mainly against IL-4, IL-13. If you see other like mepolizumab and benralizumab, the green one, they are mainly against IL-5. So depending upon that which pathway the person is following, and if we need to counter that pathway, then at that particular time, we need to start on that particular biologic or think about that particular biologic. The maximum studied biologic is omalizumab, which is anti-IgE antibody, which has been approved for severe asthma, and the people have used in refractory VKC and AKC, and the disease control is still partial, and it is not the, you can say, like the final answer, I will say. And it has been seen that the results are once again mixed, especially in case of severe presentation. So this is one slide which I think earlier was discussed, in which this is a healthy conjunctiva, and in this healthy conjunctiva there are not many goblet cells which are there, and then the mucus is secreted. Now what is happening that
Neeraj, I'm sorry, you'll have to wrap up.
I'm about to finish. Yeah. So this interferon gamma is what is happening, that when you are starting with dupilumab especially, then at that particular time, this dupilumab is actually blocking, and it is, you can say, like increasing the Th1 pathway. And that because of that interferon gamma, the mucus production reduces. And this mucus production reduces, and ultimately it worsens atopic keratoconjunctivitis. And that is why it has to be in quotient for dupilumab. So it can cause ocular inflammation leading to cicatrix. So it is not ideal for AKC with eyelid eczema. So this is my last slide, that yes, this is a spectrum of ocular IGCs, and in which immunotherapy and systemic biologicals, yes, they have a role, but it has to be person to person discussed about that. So with this, I would like to summarize that immunotherapy is only the disease modifying therapy in IgE-mediated diseases, proven efficacy in seasonal and perennial conditions, omalizumab probably in VKC and AKC, and novel agents we are definitely warranting for a better safety and efficacy profile. So it's time for precision medicine. Thank you.
Thank you so much, Dr. Neeraj. I'm really sorry. I think we have grossly overrun the time. So we'll quickly move on to the cases and try to finish it. I think, Anaida, can you present your case? Probably we'll take the questions and the discussions at the end so that at least everybody gets to present their cases. I'm really sorry. I think we just...
So, shall I begin?
Yes, Anaida.
Okay. So thank you, Dr. Shweta, for giving me this opportunity to present here today. And I would also like to thank Dr. Neeraj for setting the stage for my case over here. So my patient was a 14-year-old boy who had history of ocular allergy for 6 years before presenting to us. And he was using topical steroids 2 to 3 times every day. And once the dose was reduced to be lesser than this particular frequency, the patient was very symptomatic. The patient also had allergic rhinitis. So this was the clinical presentation. And again, this presentation is on a BD dose of twice a day dose of topical corticosteroids. The patient had significant limbal inflammation, papillary inflammation as well. His vision in both eyes was good, 20/20 and 20/25. And so we subjected this patient to a total IgE, which was within normal limits. Specific IgE did not reveal any significant allergen. On skin prick test, he had sensitivity to dermatophagoides farinae and Blumia tropicalis, and his tier IgE levels were below the detectable range. So based on the skin prick test and in conjunction with our allergist, we initiated this patient on a bi-weekly dosing combination immunotherapy with both the allergens. Along with this, the patient was given a topical course of sodium chromoglycate thrice a day and tacrolimus ointment once at night. And this is the clinical picture after 6 weeks. Although the picture looks very similar to that of the presenting visit, the patient was doing symptomatically better. And we just continued the patient on the same dose of the combination immunotherapy. And we continued this for 6 months. And this is the clinical presentation after 6 months of sublingual immunotherapy. And this patient did not require topical steroids, at least during this period. So based on this case, I would like to ask the expert panel, we could probably get to these questions at the end of the cases, that how do we choose the allergens? What is the duration of therapy? Because what is typically recommended is that a minimum of 2 years of immunotherapy should be given. However, there are no guidelines for ocular treatment. And how do we modulate the dose? How frequently do we increase the dose based on what type of response do we see? Thank you, everyone, for your patient listening.
Thank you so much, Anahita. I think we'll take the questions at the end, Serge.
Sure.
Yeah, sure.
Yeah.
We can move on to the second case.
Presentation. Mukundan, are you ready?
Yes, Dr. Shweta. Are my slides visible and I'm audible?
Yes, we can.
Yes. A very good afternoon, everyone. At the outset, I would like to thank the Ocular Allergy Working Group of EAACI and Dr. Shweta for giving me this opportunity. So I'll be presenting a case of refractive VKC where I found particularly challenging in controlling the ocular allergy. So starting with the case, a 4-year-old boy who has been symptomatic for the last 2 years was on and off topical steroids and anti-allergy, dual-acting anti-allergics. He has a mixed VKC like clinical picture featuring limbal thickening, Horner Tronta spots, SPKs, and a few papillae. So he was started on dual acting agent, anti-allergic agent, along with tapering dose of low potent steroids. Considering the age of onset and uncertainty about the refractive nature of this disease, we didn't start any topical immunomodulators in this visit. He was referred to allergic specialist. So where he was diagnosed to have allergic rhinitis as well as dust mite allergy. He was started on antihistamine and steroid nasal spray, and dust mite avoidance measures was explained. So on subsequent follow-up on 4 months later, the child was symptomatically better, but a minimal VKC activity was noted. Hence, a short course of low potent topical steroids along with dual-acting anti-allergics were continued. A month later, child was still present to us with symptoms. There was activity of VKC was noted. Hence, in this visit, a topical tacrolimus was added and a low potent steroids and dual-acting anti-allergics were continued. On subsequent follow-up, there was persistence of activity was noted after stopping steroids for 2 weeks, but the systemic rhinitis were well under control. He's been on the treatment for last 6 months. So in this visit, his olapatidine from 0.2 was increased to 0.7%. 2 months later, the child was again symptomatic with very active VKC, and we are not able to taper off the steroid successfully. So in this visit, the child was on olapatidine 0.7% along with tacrolimus 0.03% as well as on a tapering dose of topical steroids. So the patient has been referred to allergy specialist to initiate the oral cyclosporin therapy. So my questions to panel is like in case of allergic rhinitis with a coexisting ocular allergy like VKC, when systemic allergy under control, how do you manage the refractive VKC? Hello, Dr. Shweta, can you hear me?
Yeah, we can hear you. Continue with your questions. Yeah.
Okay, I'll continue with the question. Yeah. So in case of allergic rhinitis with a coexisting ocular allergy like VKC, when systemic allergy under control, how do you manage the refractive VKC? And would you advocate for the use of higher potent steroids in this child given the persistent symptoms? And what's your indication for starting systemic immunosuppression VKC? So thank you. I also encourage you guys to visit our YouTube channel, Ocular Surface Gurukul. The tagline says it all, your ultimate resource to explore nuances of ocular surface disorders and surgeries. Thank you.
Thanks, Dr. Mukundan. It was a good wrap up. Let's move on to the other case and then we'll go ahead with the discussions together. So we have Nidhi now to present her case.
Thank you, Dr. Shweta. I hope you can hear me.
Yeah, we can, and we can see your slides.
Yeah, I guess my case is also a refractive VKC. However, the present had to be dealt with a little different. We had again a 4-year-old male child, and he had been on anti-allergics on and off on steroids since last 2 years. There was no history of any systemic allergies or asthma at the time of presentation. The child's vision in the good eye, which is the 6x6 vision, did have giant papillae in the upper tarsal conjunctiva. The rest of the eye was normal. And in the other eye, the left eye, the vision was deteriorated primarily because he had a shield ulcer in one of the superior temporal quadrants of the cornea, with the posterior segment being normal. We went ahead and did the amniotic membrane grafting of this child, and the patient was, as the therapy has been advocated, was put on steroids and the anti-allergens after this. At the follow-up, and this is late October, I'm saying this because in Delhi during this time, the weather becomes cold and we see less of allergy in these patients. The patient persisted after we did EUA, after the amniotic membrane grafting was done in November. The child continued to have a shield ulcer, which actually increased in size. And we had to actually repeat the amniotic membrane grafting along with the tarsorrhaphy. despite of doing the best in 6 weeks time also in over now 3 months of the period, the child still has a small shield ulcer, which despite the best of the topical management, giving steroids as well, and taking care with amniotic membrane grafting has not been healed. So in summary, it's a child, 4-year-old with VKC, with refractory shield ulcer in one of the eye, with no systemic or other ocular complications. And my questions, I guess, are very similar to the previous two speakers. We would like to know when, specifically in children, would be the role of systemic immunosuppression in these children. What is the role of supratarsal steroids in these children? Apart from them, in this child, we actually finally are planning to do a mucous membrane grafting after excising the giant papillae. I would hand over with these questions to the excellent panel that we have here today. Thank you, Shweta.
Thanks, Dr. Nidhi. Well, we have one more presentation, and then I think we'll take the questions. Well, Suguranjani, can you present your slides and the case?
Are my slides visible, ma'am?
Yes, we can.
Good afternoon, everybody. Thank you for the opportunity. My case is also a refractory VKC. So a 11-year-old boy presented to us with a typical vernal keratoconjunctivitis symptoms. He had papillae in both his UTC. And as a standard of care, we started him on topical steroids, dexamethasone, along with topical tacrolimus ointment. And as a protocol, we advise skin prick test for the allergy testing and advised a blood test to check his IgE levels and his absolute eosinophil count. And we also noticed that he had these skin lesions as depicted here. Hence, we referred him to a dermatologist who diagnosed him with eczema and advised topical moisturizing creams for the same. He did not start him on any oral medications. On his follow-up visit, his vernal keratoconjunctivitis was coming under control, but alarmingly for us, his intraocular pressure had shot up. He was a steroid responder, and his IgE levels were extremely high. This was the highest I've ever seen, 18,000. So we had to step down the steroid from dexamethasone to a softer steroid, and we referred him to an allergy specialist who started him on oral antihistamines at this point. But unfortunately, the disease did not come under control with this. There was a poor control as depicted in these pictures. He was also starting to develop a shield ulcer as seen here, and he also had these periocular dermatitis-like picture. So we had to step up the steroid again to dexamethasone along with anti-glaucoma medication at this point, and the allergy specialist started him on a short course of oral steroids for 5 days along with the oral antihistamines. Right now, this patient is under a 1-month follow-up. His atopic keratoconjunctivitis is under control, I would say. The steroids are in tapering fashion, and his intraocular pressure is maintained with the AGM, but still his last visit IgE is 18,000. So what do we do with this case? To summarize, this is a boy who has atopic keratoconjunctivitis with high IgE levels and is a steroid responder as well. So do oral antihistamines have any role in this patient? And we do know that in patients with systemic comorbidities, these biologics, as Dr. Neeraj has already stated, that they do play a role, but as he has shown that we need to specifically target the interleukins. And so how do we choose among these? And if at all, if we are choosing, how do we choose whether we have to give these anti-IgE therapy or other oral immunomodulators like cyclosporin and tacrolimus? And how effective is this anti-IgE therapy? I would like to know the panelists' experience also on the same. So thank you very much. These are my questions in a gist. And over to you, Dr. Shweta.
Thank you so much. And I'm really sorry we are running short of time. So we don't have too much time for discussion, but really interesting cases. I have 2 quick questions, and I think Pia, is Dr. Pia around? So Dr. Pia, what is your indication for allergen testing? You are on mute. You will have to unmute yourself.
Mute. Okay, sorry. I think that you use a lot of steroids. In Italy, I am the chief of the referral center for the northwestern part of Italy. So we see a lot of patients. It depends, I think, on Indian or Italian. It depends. But when we see a vernal, we diagnose a vernal, directly we treat with cyclosporin. cyclosporin is on the market in Italy, Vercazia, the name. It's a low dose because it's 0.1. So sometimes we use the galenic form made by our pharmacy, 0.5 or 1%. Then it's a step ladder. So at last we arrive to tacrolimus. But in Italy, from our pharmacy, we made 0.1, non 0.03. So I think that is also a low concentration of the tacrolimus that you use, because in 10 years that we have used this protocol, no, we don't need a lot of steroids. Only in summer, because here it's very hot and humid, we use some pulsed therapy. We begin with loteprenol. If it doesn't work, with dexamethasone. My experience is in that way. But I am an ophthalmologist and I am working side by side with an allergist when I visit my little patients. And so the allergist helps me in giving the indication for the immunotherapy. And it was the answer for one of our panelists is that in my experience, it has to be made for 3 years, almost for 3 years, until 5 years. In our population, I speak of Italian children. And the allergy says if antihistamines, systemic antihistamines are useful for these children. But, you know, we know, being ophthalmologists, that systemic antihistamines made dry eye syndrome. So it's a cat that goes in that way. So I am not sure that antihistamines at a systemic level are useful. And the other answer is, in my experience, but it's 25 years that I treat vernal keratoconjunctivitis and atopic, that can I say, the cooperation together with the allergist is fundamental to treat these patients and avoid steroids. I don't like steroids. I prefer systemic pulsed steroids, in my experience.
Thank you so much. And I think just last closing remarks by Serge. Before that, one last question. Do we have time, Rolika, for Gonzalo? Whether just a quick thing about how do you choose between oral immunotherapy or allergen immunotherapy, sublingual immunotherapy? Oral immunosuppression versus immunotherapy. Any couple of quick points that you would like to add?
I think that oral immunotherapy as well as subcutaneous immunotherapy are two valid options, and it depends on the age of the patients, of course, and the preference of the patients. The effectiveness has been shown to be similar if the adherence is correct. So we need to take into account the preferences of the patients to make the right choice, I think.
Thank you so much. Serge, do you want to give the closing remarks?
Yes, so maybe I will respond to the clinical cases very quickly.
Yes.
In my opinion, for if you have allergy to an allergen in VKC, it's very difficult to know if the allergen is responsible for the inflammation. So the best test is to do a clinical a conjunctival provocation test if you have it. So it's the key. Then for refractory forms, in the shield ulcer, which was refractory, I would have done supratarsal Kenacort injection, because if the ulcer does not heal, it's mainly because of either subclinical inflammation. So if you inject the steroids in the eyelids, it's quite safe. and it will act for 6 months. So you will, and then you scrape the ulcer, and you can do also amniotic membrane, and you have to rule out every toxic eye drops with rule out any preservatives, any antibiotics, and so on, which will be toxic to the epithelium. And then in the patient with the high IgE levels, which is who is refractory, you should try omalizumab, which is the anti-IgE biologic, and would be very, very interesting in these patients particularly. Okay, so I think now we have to finish our session. I think it was a very, very nice session, very informative. I will thank every participant for their excellent presentations. Really, I think everybody was very, very happy for this meeting, and I hope we will have other sessions because allergies, as in India especially, but also all over the world, very important and very frequent, and we have so many clinical cases which are refractory. So we must continue to collaborate and to collaborate between ophthalmologists and allergists, and this will be the key. And thank you again, Shweta, for your very kind invitations. Excellent initiative. Thank you very much.
Thank you so much, everyone. I think if the others can also quickly switch on their videos, we can take a last picture of the group, and I think we should be done. Thank you so much.
Thank you.
Thank you. Thank you so much.
Bye-bye.
Okay.
Bye.
Bye-bye.
Bye.
Thank you.
Bye.
Bye.
Ciao.